In episode 86 of the Evidence Based Pilates podcast, we dive into the question: are there contraindications to osteoporosis? Because it is so common to hear that this population should never do flexion or twisting or some kind of variation of that. But I'm here to tell you it is not that simple. With that, if you enjoyed this episode, I have an entire workshop on osteoporosis in the VIP membership, and you can get a 2 week free trial right now with the link in the show notes. You not only get free access to the 2 hour osteoporosis workshop, but you also get access to my entire workshop library, research reviews, tons of classes, and so much more. To get instant access to the VIP membership, go ahead and use the link in the show notes for your 2 week free trial. But with that, let's get on to this new episode. All right, it's time to get nerdy because we are discussing osteoporosis, and more specifically, we are posing the question: are there contraindications to osteoporosis? Now, in this episode, we're going to discuss what osteoporosis is, what what the common contraindications that are taught in Pilates school are. We'll talk about why they do make sense, but also why it's not that simple nor supported. And then we'll go ahead and we'll dive into the 2023 Canadian Clinical Practice Guidelines for Osteoporosis. So you'll be able to walk away with tangible tools and some more clinical reasoning to help enhance your skills, knowledge, and confidence as a Pilates instructor. So, in a very simple way, osteoporosis is a bone condition or bone disease that results in a reduction in bone mineral density. And what that means is that your bones are less dense, right? There's more like holes in the bone because osteoporosis, right, has the word porous in it, which essentially means holes. So it's like an increase of holes in the bone, and it's an abnormal condition. Now, what that means in terms of like our life is that individuals with osteoporosis, strictly by the definition of bone mineral density, meaning their bones are less dense, they're more prone to fractures, right? So you're more likely to get fractures and the most common sites are in the spine, so the anterior part of the vertebral body. We'll talk about that in the femoral neck, right? That a lot of times results in a hip replacement, and then you can also get it in the wrist from what's called a Fuchs injury. A Fuchs is kind of like a fun acronym: FOOSH. It stands for fallen on an outstretched hand. But anyways, we'll put that in like the fun facts bucket. Okay. Osteoporosis just means the bones have less density, and the reason why that's a problem is that you're more likely to have a fracture. And then the individuals that are more likely to have osteoporosis are like postmenopausal women who are usually underweight, or that would be like the those are not the only people, but those would be like the classic individual would be that. So then you have that. Let's say it's like an 80-year-old or 85-year-old female who's been underweight her whole life, and then she falls and breaks her hip. That results in big problems because it's going to be really hard to continue to stay moving as you recover. So, anyways, this is the problem. If you want to learn more about hip replacements, go to the previous episode. With that said, it is in regards to exercise for osteoporosis, we're just going to stay in the lanes of like contraindications and fractures, not so much of what to do. I believe it was episode 7. It was like way back when, where I did an osteoporosis episode. And there's also a free workshop available to you, a 2 hour workshop. I'm not charging you anything. It's a 2 week free trial in the VIP membership. I just want to help you become more skilled, knowledgeable, and confident. So you can just do that, start your free trial. If you don't like the membership, just cancel it. You get free education. But with that, the contraindications that are generally taught are to avoid flexion and twisting. I have seen so many variations of this, and I'm guilty of even teaching them 100%. Okay, but you learn more, as you learn more, you know more, and then you do better. So with this, I've seen it so far to be like no. It was like literally no flexion, no twisting, like those words. So you had to be in neutral or extension, right? And they didn't even talk about side bending, right? Like we just like I guess mermaid doesn't exist. But anyways, so it's like none of that. You're not allowed, right? So like don't sit down because your spine flexes every time you sit. Don't get out of your car. Like it makes no sense, right? And then there are more reasonable ones that say avoid either loaded flexion or rotation, which is also really ambiguous because what does loaded mean? Gravity, right? That's load. Um, or um, or does it mean like over 5 pounds, like a blue spring? Like what does that actually mean? And then other versions would say avoid end range or end range and loaded flexion and twisting. Now, those are more reasonable, right? And also manageable. Although for Pilates, that has such an emphasis and pride in like moving the spine in all directions and like increasing range of motion, all of the things. It's like with like that is like the last thing that this population would need when following those common contraindications. But there are no guideline-based contraindications for for this population, for osteoporotic populations. That is directly from the ACSM guidelines, the 11th edition of the ACSM guidelines. There are no guideline-based contraindications for exercise for osteoporotic population. Now, we do have what's called considerations, right? But sometimes considerations get confused with contraindications. And that's how fear mongering works, right? Or not fear mongering, really. Maybe that's the wrong term. Sorry if I offended. That is how like fear based teaching works. It's like if we have to consider it, there's no way, right? We're not doing it. You're not allowed. Okay, where it's just it isn't that simple. It does make sense, right? For some people, I would not do that. I would not do the loaded end range flexion and twisting. No way, right? Like my 87-year-old client who hasn't exercised for 17 years and has had 6 vertebral fractures in the last 5 years. No way. Like that's totally high risk, right? And you have osteoporosis. Like that would be an example. But I'm going to make a case for maybe the person who's been a Pilates practitioner, maybe the Pilates instructor who recently got this diagnosis can, still do short spine. Maybe. These are just ideas. None of this is medical advice. So why do these like ideas exist of like avoiding flexion, avoiding rotation? Like why this, right? Why not big toe extension, right? Why is it the spine? Well, spine fractures are common in osteoporotic populations. Oh, fun fact, by the way, people with osteopenia are 50% more likely to get a fracture when compared to people with osteoporosis. But osteoporosis individuals, in terms of bone mineral density, are way more vulnerable because they have less density. Huh. Maybe bone mineral density isn't the only variable because if it was the only variable, the less density you have, the more fractures you would get. Yeah? That's just stating the obvious, but that's not what we see. There's more to the picture. But in regards to this, what are we being so cautious about? Okay, it's challenging to talk anatomy verbally. Okay, but I will do my best. And if you're like, I want anatomy, there's an anatomy course coming out with evidence based Pilates. I'll be your host. And that's going to be coming out late 2024. Okay, it'll be like a holiday gift for you. So, with that, we are avoiding what's called a wedge fracture, which is a compression fracture of the anterior aspect of the vertebral body. Did you just get dizzy? Oh my God, anatomy. Don't worry, I won't bore you. Okay, anatomy. There's the pokey part on the back. If you just like touch the back of your neck, you'll feel bones, right, where your spine is at. Okay, that's your spinous process. If you were to go on the other side of that bone, okay, that's where your the vertebral body is at. On the very front of it, okay, that is where the fractures a lot of times occur, and they occur from compression. Compression would be like gravity is pressing down on your body, and we're all under compression, right? If you're standing or sitting, you're all compressing your spine. Compression is the force for good. But when you have too much compression, you can fracture, right? Any tissue has a fail point. The fail point is earlier for osteoporotic populations because the bones are less dense. So when you flex forward, what happens is that we increase the pressure and therefore the compression on the anterior part of the vertebral bodies. So therefore, if we have a vulnerability to compression fractures, let's reduce the compression there. Is there something else we could do? And it's very similar for rotation, right? So rotation, you're getting a shearing force as well as the compression if you were standing, right? And things like that. If you're lying down, maybe it's a little different depending on what you're doing. But regardless, we're trying to avoid having an increase of force and going to tissue failure or the vertebral body where this population is vulnerable. It totally makes sense, right? It's like, oh, and it's explained like that. I get it, right? We're not just being mean. Right? Don't be mean, right? Unless you're teaching the 100, then you're mean. But with that, that's the logic. The logic behind the flexion and twisting, it's not flawed. It's not flawed. It's just misunderstood, right? Or it's just taught in like such a conservative way as if it's a black and white issue. Watch out for black and white reasoning. Okay, if you ask enough questions, they all fall apart. Maybe not. Maybe one of them doesn't, but most of them do. Yeah, this one does. Yeah, hang in there. Okay, if you want more of this, oh, that workshop is good. It's in the show notes. So we want to avoid having an increase of compression when we are vulnerable to compression fractures, right? But sometimes logic like that doesn't always work or it's not necessary. So in this case, it would work for someone who is very vulnerable, okay? But it's not that simple because it's not just bone mineral density that predicts fractures. Why? Because you're a human, right? You're not just bones. And a reference here, which I will show on video if you're watching this on like Spotify or on YouTube, right? You'll be able to see the video. It says, but I'm going to show you the clinical practice guidelines. Okay, I'm also going to talk to it, so you're not missing out if you're on podcasts and just audio. But this is the clinical practice guidelines for management of osteoporosis and fracture prevention in Canada. It's a 2023 update. Now, what I'm going to do is I'm just going to go ahead and show the risk factors that they show for fractures. Okay, they have this handy chart, okay, which is super cool, but I'm not going to go through everything because I'd bore you to death. But risk factors. Okay, risk factors for a fracture for osteoporotic populations would be a previous fracture after 40 years of age. So what that means is like you shouldn't have gotten a fracture from this kind of force. Like you just kind of bumped your hip on a table, but you broke your hip. That's weird, right? It doesn't have to be that simple, but it's just stuff like you shouldn't have broken a bone, but you did, right? Um, with that, that's one. Then glucocorticoids, right? So if you, it's what this basically means is if you've had recent and long-term use, so you've been using it for more than 3 months. Okay, sometimes you have to do that for other medical conditions. And then if you've had a fall, okay, if you've had 2 or more falls in the last year, okay, you're at a higher risk for fractures. If you had a parent that had a hip fracture, okay, you are also more vulnerable to fractures. They're doing that to kind of satisfy genetic predisposition. That's not easy to do, but parents, you share similar DNA. Now, if you had a body mass index of less than 20, what that means is you're underweight by classification of the BMI. Okay. If you have secondary osteoporosis would be like you have type 1 diabetes, which is associated with osteoporosis. So it's like you have another condition that has been linked to osteoporosis. All of these things are about probability, right? Like, are we increasing or decreasing the probability of a fracture? Other things would be that you are currently smoking. Even if you don't tell anyone about it, because there's secret smokers out there. So if you're currently smoking, or if you have 3 or more alcoholic drinks a day, even if you put 3 glasses of wine in one glass, it's still three. It's still three, everyone. Okay, I know it's fun, but anyways, I'm having fun. So the point with that is that, like, those are risk factors in addition to your bone mineral density. Okay. It's not just your bone mineral density. Now, can you see how it's just not that simple? Okay. So one thing I want to reference is what's called a Frax tool. A Frax tool is a free online resource that is utilized by healthcare practitioners. Now, we are not healthcare practitioners as Pilates instructors. It is outside of your scope of practice to provide any kind of diagnosis to any client, but this or to any family member. Um, but with that, this it's a free resource on the internet that you have access to, and your clients have the right to use it. You have the right to use it, and then you can utilize that information to either guide them to a healthcare practitioner or to inform your decision. It's not illegal to look at a percentage and then like make a decision, but it would be out of scope of practice to then put a diagnosis on somebody or anything even close to that, because that's not even close to our scope of practice. What is a fractal? A fractal is essentially putting the information that, like the risk factors, you click on whatever risk factors you have or your client has, such as a previous hip fracture, a parent hip fracture, if you're currently smoking, all the things I listed. You do that, you put your BMI in, you put your age, you put your continent and where you're from. I don't know exactly why they do that, but they might just be doing that for their own data. And then if you can do this without knowing your bone mineral density. It's a little bit better if you know your bone mineral density. But you put all of that in there. They actually have rheumatoid arthritis in here too, which is interesting because that wasn't in the guideline. But anyways, you put all that in there, and then you get what's called a 10-year fracture risk percentage. Okay, so that is this estimation of your 10-year risk getting a fracture. So here's the rub, right? So if you have a client who smokes, they drink. They're like your funnest client, right? They just want to party with you, right? And they do Pilates, but they also have osteoporosis. They've also had 3 fractures after the age of 40, and their parents had hip fractures. They're going to have a pretty high percentage. Oh, yeah, and they're 82, right? So they're going to have a pretty high percentage. Okay. Whereas maybe you are teaching another client and they are a 52-year-old female that is of quote unquote normal weight, according to a BMI. They have no risk factors. They don't have rheumatoid arthritis. They don't have a fracture. Their parents had never had a fracture. They don't drink. They don't smoke. They've never taken glucocorticoids. None of that. But their T score came back at 2.6, which means that you would have a diagnosis of osteoporosis. They might have like a 5 or 6%. That would be considered low, right? Under 20 is not considered high, from my understanding. I believe that's in the guidelines. So with that, a 6% fracture risk in the next 10 years. And let's say this person is 52-year-old. They've been doing Pilates for 25 years. They've been doing the entire original repertoire, all that bending. Now they come in and they have an osteoporosis diagnosis. And we go, oh shit, we can't, oh shoot. I said shoot, oh shoot, we can't, okay, we can't bend your spine forward anymore or twist. Or maybe we can't go to end range. And I'm here to question, like, is that true? Is that true? They don't have any other risk factors, but they did have lower bone mineral density on this scan. That is true, right? So they do have a risk factor, but they don't have any others. That's completely different than the 84-year-old or whatever who smokes, drinks, has a history of fractures, and so do the parents, right? That individual is probably coming up with like a 28% fracture risk, right? Meaning that would be of significant concern. I'm probably not short spining with the person that doesn't have a history with Pilates, like they haven't put these stresses in their body before, and they have a huge risk, right? They have a high risk of fracture. Then it's like, no, like there's total logic to those what we call contraindications. They're not contraindications, they're considerations because it's not black and white. Okay. like uncertainty and nuance isn't sexy. Uncertainty and nuance doesn't get you Instagram followers. Uncertainty and nuance doesn't make people you talk to happy a lot, right? Because we all want an answer. I do too. I just want black and white answer, right? Can you just tell me how to make $1 million, right? But there's like so much nuance to it. Um, but it's the truth. We are our body's just like an ecosystem. Okay, we are a chemical reaction, and we can't just look at one part of it and say like that's the only determining factor. Okay, but it's part of it, right? There are reasons when we wouldn't flex and twist, right? Under load, at end range. Okay, someone who has never done that movement before, right? We're introducing a new stress to the body, and they're at a high risk. That's so much different than someone whose their body is so accustomed to short spine. They've been short spining. I'm gonna say short spining is the word. It is now. They've been short spining like longer than I have been. Been doing it for 25 years. And now I'm gonna take it away from them because they have osteoporosis. They have no other risk factors. Now, if they had osteoporosis, but they also had a ton of other risk factors, that's where you might have to have a difficult conversation and handle it in different ways. And this kind of leads to another thing that I'm going to go off script a little bit is there's like fear of litigation, right? 100% valid. I live in the United States. Okay, for anyone who's not here, you can get sued. I can get sued by I bet you. Okay, well I don't know about the mailman, but let's say my neighbor comes over because they want to borrow some sugar. They slip. It's their fault. They tripped on their own 2 feet. Okay, and they fall on my doorstep. I get sued. I did nothing. I did absolutely nothing. It's on my property. They blame my stairs. Or I give a client coffee and my coffee cup doesn't say it's hot, even though you can see the steam. And they say, hey, I want it extra hot. And I say, hot coffee coming your way. Okay. It doesn't say it's hot. I hand it to them. They get burnt. I get sued. So like, yeah, if you're teaching this and the client gets a fracture, you're going to want to cover yourself, right? Just like someone who doesn't have osteoporosis, sign your waivers. Don't I've had clients try to talk me into that. No way. Right? Have all your clients sign waivers, especially in America. Yeah. Anyways, with that said, if this was something new and you're like, "Ah, I've been taking this moving away from your client, first of all, you're not wrong. Second of all, we have all learned and then unlearned. If you've been teaching more than 10 days, you've learned something and then unlearned something. And then you thought about this client and you're like, oh my God, I can't believe I told all these people these things. I'm such a dud. No, you're not a dud. You're a Pilates instructor who's learning. What I would even say on this topic a year ago is different than what I would say now. Yeah, you listening that you've asked me and reached out to me and I've given you answers you might not like. Sorry. Okay, I learned more. And you get to do that too. Okay, if you choose to. Nothing is forced on you. This is not medical advice. This is just information. Okay? It's possible. It's possible that there might be a person with osteoporosis that can short spine. Okay? But it wouldn't be unreasonable to generate like a waiver, like an osteoporotic specific waiver that says, "Hey, you have acknowledged that you have this diagnosis. This is you did a frax tool, and like this is your rate, this is your percentage. Okay, that's not illegal. Say that that's your percentage, and you understand the risks of doing Pilates, XYZ fractures, whatever it is, and then you have them sign off. Okay, like yes, I agree to bend my spine. Okay. That's not unreasonable to do. And if they're not willing to do that, oh, I'd be conservative as shit with that person because they're saying, no, I reserve the right to sue you. Anyways, that's from a legal standpoint, like that's not unreasonable to do that. If if you are studio owner, you have powers over that. With that said, I want to go ahead and just share with you a little bit of what the guidelines have to say regarding exercise. So these are the 2023 guidelines for exercise. Okay, exercise on osteoporotic clients. they have this really easy chart to read, which is really nice. Now, I'm not going to go through all of the points. Okay, I go through all of the points in the workshop. I break that down to the T. So, but what I want to do is go to point 1.4. Okay, 1.4 on this, and it is what's called a good practice statement. A good practice statement means that it's something that's necessary for, this is made for healthcare practitioners. It's something that's necessary for healthcare practitioners, and it's a consensus, but it's made on indirect evidence. Like, we don't have direct evidence that this is true, but there's enough logic and people that agree on this that we think it'll be good. But we also can't pretend that we have strong evidence on this. So it's considered weak evidence, but good practice, otherwise known as it's opinions from smart people, which aren't bad. They're not bad, but we just don't have clinical trials to support it. So, with that, point 1.4 states activities that involve rapid, repetitive, sustained, weighted, or end range of motion, twisting or flexion of the spine may need to be modified, especially in people at high risk of fracture. The key part is that it says may need to be modified. You can say it may need to be, or it may not need to be. It depends. It's not black and white. Okay, that's what's called a consideration. A consideration is not a modification. However, as they stated, if someone is at a high risk of fracture, they have a 34% fracture rate for the next 10 years run through the Frax tool. That's just an example, right? And they've had six vertebral fractures in the last decade. Oh man, yeah, that's high risk. I would probably not teach them crisscross, right? And I'm not a conservative instructor, right? I'm also not a reckless instructor. I'm a movement optimist, right? I'm a movement optimist who you better have damn good evidence for me to take movement away from someone. Okay, because we only have 20% of people moving enough in the world. And now here we are taking movement away from people when we don't even have guidelines to support that. We don't have guidelines to support taking flexion and or rotation away from all osteoporotic people, but we have tons of courses that say that tell us to do that. And the evidence is in the instructors that spread the messages. And you're not wrong. You're never wrong for sharing messages that you paid thousands of dollars to learn. That's on the educator, right? And even if the educator is like, "Oh no, I did that years ago." Fine, well, change it now, right? I certainly would. I've taught avoiding end range flexion and rotation, right? But as you know better, do better. And I hope that this podcast episode has been useful, just to plant the seed of critical thinking, to plant the seed of being curious, right? Being curious, and how can we keep osteoporotic individuals moving, just like people that don't have osteoporosis. Because guess what the physical activity guidelines are for osteoporotic individuals? You'll never guess it. It's the same as people who don't have osteoporosis. It is 150 minutes of moderate intensity exercise plus 2 resistance training sessions per week, or 75 minutes of vigorous intensity exercise plus 2 resistance training sessions per week. With that said, should we teach short spine and elephant and crisscross to osteoporotic clients? It depends, because you should always be working with the individual in front of you and allow yourself and them to make an informed decision, because that is client-centered care, allowing them to be informed on their condition, the pros and the cons of any Pilates decision that you make with them, and then collaborating with them to make a decision together. Because you want to know a good reason why not to teach flexion and rotation is? Because your client is afraid to do so. Your client says, "I don't want to do that." They set up a boundary. That's enough of a reason. But if your client is advocating for them to move and they're frustrated by these rules, you can dive a little bit deeper with them. And I hope that this podcast episode has allowed you to consider the nuance of fracture risk with osteoporotic clients. I am by no means saying like screw anything you've ever learned. You can flex and twist away. That is not what I'm saying at all. What I am saying is that there's more to the discussion than a simple sentence that says no flexion and twisting, because it's something that's like, it's kind of true, but extremely misleading. And if you want to take a deeper dive into this, okay, and tons of other topics, if you like nerdy stuff like this, if you want to learn science based instruction and elevate your skills, knowledge, and confidence as a Pilates instructor, you can get a 2-week free trial of the VIP membership right now with the link in the show notes. You can get instant access to the osteoporosis workshop. You also get instant access to the entire VIP membership, which includes our private Slack community where I give you personalized mentorship 7 days a week. Okay. I work one on one with people all the time through video messages to go ahead and help them with any problems that they have. With that said, I hope you enjoyed this episode and I hope to see you in the VIP membership. And I'll definitely see you in the next episode.